Let's now move on to the last talk of the masterclass, the more complicated scenario doing surgery for diabetic retinopathy. Let's learn some tips and some tricks. Now, coming to the tips, make sure both surgeon and the patient are ready to operate. Make sure the expectations are very realistic. Visual acuity in the following eye is very important, especially if the following eye has had complicated vitrectomy for diabetic. That is a very important indicator that the prognosis in this eye may be bad too. Patient must understand that there could be need for multiple surgeries, and patient and surgeon both must accept the possibility of poor post-op visual gain. The second tip is do as much preoperative PRP as possible, whatever retina in the periphery is available. Preoperative anti-VEGF therapy does reduce intraoperative complications, so plan it. A good metabolic control, and very important, know when not to perform PPV. For example, a scenario like this, there is a tractional retinal detachment which is quite away from the fovea. Patient has good vision. So these are the kind of scenarios where surgery can wait. Now, coming to some of the tricks, I think the most important trick is to choose the right instrument. We have very good cutters now, which give us ability to work close to the retina, and there is more access to tissue planes. These cutters are the ones which can be used both for the segmentation as well as delamination. As a result, just with the single instrument, you can complete the surgery without need for scissors or multiple instrumentation. And they also have ability to manipulate tight adhesions in the mid periphery. Now, let me show you how these some of these surgical videos I'm going to show you to give you an idea how these surgical treatments help. Now, first thing is you can see after doing the core vitrectomy, you go to the area where there is traction. The most important step is to find, like this one, a plane of delamination where you can insinuate your cutter. If you want, you can use proportional reflux at this stage to separate the tissue from the retina. Divide the tissue into multiple segments as you can see. Now, this is the technique which is conformational delamination because your cutter is faced upwards and the membrane is coming into the port. So, similarly, you can see the whole area we have divided into multiple small segments. Each of the segment is then taken care of. One very important thing is the diabetic during diabetic vitrectomy is when there is a bleed, tackle it there and then only. Now, when we come to the techniques, this is what is called fold back delamination, which means your membrane is free. In such a membrane, you can keep your cutter behind the membrane so that the epiretinal membrane feeds into the cutter. It's very safe because your retina is protected. But you also understand that's not real life. Many a times you may have to do this, which is feeding the membrane directly into the port, and that is called conformational delamination. When we reach the mid periphery, in some patients you will find the vitreous very much adherent in the mid periphery. So, what you can do at this stage is you can use in the mid periphery, you can use sharks. Skin or any forceps that you had just to nudge the vitreous adhesion to find a plane, and then you can use cutter to separate it from the surface of the retina. One important thing is when we are working so close to the surface of retina, you have to have very high cut rate and very minimal vacuum. It's basically the cutter is working as a scissor. And as you can see, this bleeder is here. I'm continuing, but ideally the bleeder should be taken there and then. So, as you will now notice, the cut rate at this point was 10,000. If you have 20,000 cut rate, that works very well as well. So, you start chopping it, you go very close to the surface, you have cleared that, and then you move on to the next area. Again, insinuate your cutter, use conformational delamination, segmenting it into two. Once you have segmentation, then you can cut the different segments into multiple parts and treat each one of them one at a time. So, this is before and after the surgery, the same patient. Now, the trick number four is if you are lucky enough, or if you have, microscope integrated OCT, you may sometimes use the OCT. Just the cutter can be used to look at the OCT where the retina is so that you are not causing any retinal breaks. But in reality, to be honest with you, I don't find this very useful and practical. But what is most important thing in retina, especially when doing surgery for diabetic vitrectomy, is to identify vitreous cases. Now, many of these patients would have multiple layers of vitreous layers split uh, into two quadrants. So make sure to inject Canacort so to be very confident that you haven't left any vitreous behind. You may want to use OCT to confirm there is no vitreous or epiretinal membrane, or you may want to even inject dye. I do not do ILM peeling in all my diabetics because ILM is the food processes of Muller cells. So we don't unnecessarily want to destroy the food processes, but what you essentially need is a very meticulous cleaning of the vitreous as well as the epiretinal membranes, which may be coming. So this is just to show you a video, a complete video, how a small gauge vitrectomy will work. You go to the disc in this patient, a very small truncated PVD, because it's not PVD, it's just, it gives you a space to enter. Using the same cutter, you are finding the plane. You can go in different directions, but be careful when you are using your cutter, it should be away from the retina. And if you are working in the right plane in diabetics, that is the most of the battle is won because it's just entering the right plane. Now, here you see, you elevate the fibrovascular membrane, you go behind it. Some of these fine cutters give you an advantage of changing the direction, which may not be possible with scissor. Now here you can see when I'm in the nasal retina, I have just changed the direction of the scissor without doing anything to my hands. Direction of the vitrectomy cutter, I'm sorry, without doing anything to my hand. So this is what it is. You work close to it. You can use this is again fold back, conformational, whichever you want to change. You can use the same cutter to aspirate. This is diathermy. I'm using laser to diathermize, but you can use any diathermy. Just make sure your diathermy power is very low so that even if you press the foot switch very high, it just doesn't cause a hole in the retina. So I will move it a little fast forward to show you how these membranes in the eventually they are removed, all of them, and this is how retina looks like at the end of the surgery. Uh, it has also reduced now the need for bimanual dissection because they're so efficient. And in this one, I'm doing bimanual because the case was very bad. But again, you can see it's using the forceps and the cutter just to find the plane and keep moving along with the it. Only thing in diabetic patients is have a lot of patience so that you enter in the right plane. And if you are in the right plane, you will be successful. So, to conclude, important to have good pre op preparation and counseling, realistic expectations, meticulous surgical planning, and live for another day. By this, I mean if there is too much intraoperative bleeding, if you're not able to handle, don't carry out in the hazy media. Leave it for the time being. Maybe 2, 3 weeks later, you will have a privilege of entering again the eye and doing a better surgery. Thank you very much.